In this session, I'm going to be joined on the podium shortly by Bev Smith, who you met earlier, as well as Phil Offer, who's the CEO of BestMed. And we're going to be discussing wellness, digital hospital in the home, and the Denmark model of proactive intervention. And you saw a bit of that earlier today. What I'm going to do to kick off the session is I've got a short video with Erik Hans Hendrickson from Ampla in Denmark, who's going to talk about the rehabilitation, proactiveness, and we're going to watch that, and then I'm going to ask Bev and Phil to come to the podium and have a conversation. So if I could ask for the first slide, please.
What is exciting is the fact that right now we are rolling out telehealth to all chronic patients in Denmark, starting out with COPD lung patients. And that means that we are in a process of accustoming every chronic patient to take the responsibility for their own health, to be involved and empowered to make their own decision, but also to be the master of their chronic disease, being able to see day by day how is the state of the chronic disease, and being able to take more actions on their own regarding their disease. That is really exciting. I think in 5 to 10 years, we will have covered the major chronic diseases, starting out with COPD, moving to coronary heart disease, diabetes, but also mental health and psychiatry, stress and anxiety. If you can reach out and give them the toolkit, empower them in their own home, I think it can make a very dramatic effect on the cost of those diseases for employers and for our society and for the healthcare system. Ensuring that the patient actually report data on the chronic condition every day. We're ensuring that if that reporting result in what we call a red condition, meaning a deterioration is detected, we should do an intervention that is done immediately. Actually, a call center will contact the patient, or the patient will contact the call center. They will immediately have a video consultation with the nurse, or actually with a medical student. I'll come back to that. If the nurse establishes well, we need to do an intervention. Immediately, as a second layer, they will have a lung specialist in contact with the patient. And the patient, they love it, because as I say, hey, even before I feel that there is something going on, it's detected by my measurement. Immediately, I talk to the specialist, the lung specialist, if that is needed, and immediately something is done. Typically, some extra medication, and if need be, they can also be sent to the hospital or to a clinic. Also, what we're seeing is that when we get to that point that the patient spends 5 minutes every day taking out their tablet and the 2 measurement devices, it becomes a habit for the patient, like brushing your teeth, polishing your shoes. And of course, on the one side, this ensures that in 100% of instances, we discover deterioration. On the other side, if there's no deterioration, if they get a green feedback, the reaction by the patient is, okay, the system has detected that there's nothing going on. I feel safe to go out shopping, go to the theater, movies, visiting the family. And we see that in the research. We have done some randomized studies where we see that patients in this program, they have twice as much social activities, visits to family, going out, than patients in the control group. And we're also seeing that they had 3 times as much traveling, because as I said, well, I'm not concerned to travel because I have my toolkit, I bring it with me. I do my measurements every day. And by the way, I have my digital link to the call center regardless of where I am. So it means a lot for the patient. It also means a lot for the healthcare system, because what we're seeing is that hospitalization for these patients in this program is reduced by more than 50%. Visits to the emergency room reduced by close to 70%, the same for outpatient visits, and also visits to the DP is reduced by more than 70%. And there's a good reason for this, because if you think about our current healthcare system, for those chronic patients, what's going on is when they have a deterioration, they need to get to a point where they feel the deterioration. Then they contact their DP. In Denmark, you need to wait for an appointment with the DP. And you go to the DP and the DP said, yes, I can see we need to do something here. Maybe the DP will change the medication, and then in some countries, you need to wait for the prescription to reach the pharmacy, not in Denmark, but in a way. But if the DP refer you to the hospital or to a clinic, then you have some additional waiting time. And why do you have these time lapses between contacting the DP, getting the appointment, and the DP to the hospital? This deterioration or infection develops, and then suddenly you end up in the hospital with a pneumonia if it's a lung patient, like in this case. And this is the difference between the Evital care model and the current healthcare system. We have this treatment model which ensure that we can discover things at a very early stage, immediately establish an intervention.
I had intended to start starting with these slides, which were about the fact that in Denmark, led by this gentleman who was who designed the aging health system in the 1990s, he has since then set up this new company, it's 10 years old now, Empla. Now, it's a beautiful business model about intervention, early intervention. I'll just briefly describe it before I ask Beth and Bev and Phil to come to the platform. In very simple terms, they specialise in looking after people with either lung challenges or heart challenges, and they give each of them a kit that has 3 devices on them, 3 separate devices depending on the ailment, and the person has to take a measurement every morning and every night, and they have to put the data into the system, which is collected at the head office, if you like. So what he was explaining is that, well, firstly, to my mind, it's the most fabulous business model because he has tens of thousands of people on this program and they're all paying him $65 a month. And as he says, we do very little. They pay us $65 a month. They do the testing in the morning and the evening. They put in the data. Our systems analyse if anything's happening. And if the systems identify something's happened, the telemarketer rings them. The only time that we really have outbound calls is if they don't put the data in. Then we ring them and say, why haven't you put the data in? And they always apologise. So what he was saying throughout all of that was immediately we identify something's happening. Immediately we can respond, and so on and so on. And thus he gets the results that he has. So he's got tens of thousands of people paying him $65 a month with very little manpower and so on behind. But he is reducing his hospital admissions, et cetera, by 50% and higher. So it's an example of somebody who's thought outside of the normal procedures, which is what I was hoping to demonstrate. So what I wanted to do is bring Phil Offer and Bev Smith to the podium, and we're going to have a conversation about wellness and systems that can be expanded for rehabilitation and intervention. And Phil's going to lead this conversation.
Thanks, everybody. And go eftermiddag, which is a bit of Danish for you, for good afternoon, for those who want to know. We're talking a bit about Denmark today, but then also looking at how do you bring it back to an Australian context as well, actually, and what can work in this sort of area. So, hey, Bev, good to see you again, and thank you for your insights this morning.
Thanks, Phil.
From what we've heard so far, what do you see as the barriers that could be from bringing that Danish sort of preventative model in? There's obviously huge potential, but how do you make it work sort of in Australia?
Yeah, look, it's a really interesting one for us in Australia. We often refer to the Nordic models as the exemplars, but it's not so easy to translate that into the Australian economy. In Australia, interestingly enough, when you compare us with the OECD, we have double the average spending on healthcare as a country, but half the spending on prevention compared with other OECD countries. So The challenge for us really is funding. It's very difficult to achieve reform without funding. And certainly, you know, as we heard in a number of the sessions this morning, how do we actually get ahead of the curve? Healthcare is really a very reactive model. Prevention is all about being proactive and getting in ahead of the events actually occurring.
Yes, because I think in Australia, particularly when you go to the healthcare side, having worked in the GP sector for a few years, the medical benefit schedule is episodic care. So, and is generally built as one way. Very few times actually does that information come back. So GP refers to specialists. They don't necessarily know when you pick up that letter or when you make that appointment. So we're still very sort of disjointed sort of in there. So you're right, it's not just the amount of the funding, it's actually what's the incentives sort of behind it, I think, that are very sort of important sort of in there. Is there any...
As you say, Phil, I mean, it's episodic and it's fragmented, so the information doesn't flow. So again, when you're looking to more of a preventative model, you're really looking to identify those health risk factors much earlier and understanding what the appropriate prevention or early intervention looks like. And I think, again, just the way our data across our health systems is so disaggregated, it's very difficult to get that rolled up view in a more continuous sort of storyline about someone's health and well-being.
Yes, and I saw, I mean, your presentation earlier this morning, you talked about how you bring that sort of data together. How much, I mean, it's probably impossible to know everything at the moment, but how much do you think if you've got the core data, can you get into your systems from across the various sectors?
Look, aggregating the data that we have is the first hurdle to that, and we have a significant program underway in terms of how that's aggregated. As I mentioned this morning, we're a business of acquisition, so we have had multiple CRMs, multiple ERMs. So we have a process underway in terms of aggregating the internal data. But really what we're curious about and exploring through some other partnerships is how you start to add additional data sets to that. And how it starts to build out a much richer view. If you're wanting to personalise healthcare, you're wanting to personalise someone's experience, you really need to be in a position where you can start to anticipate what the next best health action is. So that's the program that we have underway.
Excellent. I mean, and I would say from our experience at BestMed, we operate and partner with about 1 in 2 aged care homes that are in Australia. And so having that medication data that is linked between the pharmacy, the GP and the aged care home, there is only one live record. The F word of fax has been eradicated, at least for medications. And you get this huge benefit of having that two-way modelling in there, so you can actually be able to understand where's the next level of care going, spot the risks, and more importantly, as he was saying there, discover what's actually going on. So you don't need to send somebody out there necessarily to actually see what's going on at this stage. Now, as well as the hospital in the home program we talked about this morning, you're doing a lot of work in preventative healthcare too, and have partnered with Amwell sort of in the States. What does that bring in terms of capabilities to Amplin?
Look, again, it's about recognising that it doesn't have to be built here. So Amwell are a technology platform that provide services across the US and also into the NHS in the UK. And they have a number of programs that we are translating into the Australian context for digital prevention. So again, looking for models where it's not reliant on a synchronous conversation with a human being, where there's opportunity for asynchronous messaging back and forth. There's some really positive statistics out of the NHS, for example. 700,000 people have been through Amwell's program that they run on behalf of the NHS. There's something like a 93% satisfaction rate. So these are sort of modules that people can work through that provide that sort of positive health literacy education, and are also making coaching-based advice into people. So there's a couple of different models that they offer. But importantly for us, it was about looking around the world, seeing who does things better than we might, moving beyond the mindset of we have to build and own everything ourselves, and actually saying, well, how do we partner in a strategic way to bring that capability to Australia?
And obviously in the States,
just on that, Bev, those programs with the NHS, they're not just simple programs like, did you put sugar in your coffee today, are they? They're actually quite complex programs. They can go to mental health, they can go to a whole range of things, but they are getting a 93% satisfaction rate by people who aren't well, who have had to interact with a non-human. Have I got that right?
That's correct. And I guess what we're finding is what aspects of the experience generate great outcomes for people. So while we've all held the view for a long time that it has to be a face-to-face, in-person appointment, for example, around mental health. In fact, what the significant data is showing out of these programs is, in fact, it's often through web chat, for example, that people actually prefer to interact. We've had huge growth in those channels, and you're putting people through an intensive behaviour change program, but it's being delivered through a model that they actually find a much safer environment to interact around mental health challenges.
So if we follow that through, if you've got somebody who is got mental challenges, you can actually reach out proactively before it escalates, involve them in one of these programs and achieve significant change.
Indeed, and it's about understanding, for example, just what those sort of preliminary or early factors might be. So if someone's been discharged from hospital with some sort of cardiac event, what the data is showing us is that those individuals are more predisposed to mental health challenges as part of that recovery. So while historically we may have focused on sort of cardiac rehab and the actual organ, we're sort of learning a lot more around, well, what are the psychological supports that would also help an individual through that challenging period as they rehabilitate.
And in those programs, how much, when you sort of go outside your current sort of professionals you've got in there, when you go back to the health system, what's been the reaction sort of there in terms of, are they accepting of the advances you're doing, or are they more sort of trying to protect that and go, okay, I want to be in charge of that model of care? Yeah.
Look, as many in this room would know, there are different views across the health system about things like hospital in the home, what type of care is best delivered in a hospital setting versus an in-home setting. So I think there's a journey in that space. Yep. But I believe somebody said it this morning, like the kind of key to unlock is trust and reliability. So if you're delivering that service reliably, they understand that there is continuity of care, they're getting regular feedback on how that person is progressing. That goes a long way to building those referrals.
And I thought probably our legacy from COVID would be that, well, we did this in a period of year. I mean, I worked in emergency telehealth during the COVID period. We sort of had to do it at that point, actually. So there's a huge clinical database as to how we managed to keep people, meeting with emergency specialists, and they didn't need to be seen in person at that stage. So
that's it. And I think, again, there's a process of educating people around that. They're like, oh, I didn't know that I could receive that service via a video call. So people sort of take up the service experience, what it's like, the flexibility and accessibility that it improves. And then I think, those people are out sort of great word of mouth in terms of what the experience is. We're also working with a number of university partners around how we're capturing the data and the research to understand the clinical efficacy of those models.
And interesting, when you try and sort of localise something, it's not always easy. Outside of this sector, Bunnings learnt that by flying to the UK, flushing $1.7 billion down, and then flying straight back in 2 years' time.
Yes.
Have you had to localise or found bits that just don't work when you take it from those other countries?
Yes, we have. Yes. So, I think you can anticipate what you will need to change to make it culturally appropriate for Australia, as unusual as that sounds, given we are so multicultural. Yeah. But there are certain things in the scripting, for example, that we've had to modify just to make sure that it's appropriate for an Australian audience.
Right, you were there. And in terms of the choice of Amwell, because there were a number of partners in the States, how did they stand above Livongo or Teladoc or the rest?
Look, I think, the fact that they're running programs into very large jurisdictions through the NHS in the UK and also in the US. So there's a sort of breadth of capability that they bring to it. But equally then, it was around alignment on what we're trying to achieve, the impact we're trying to have on the health system. Obviously, when you're bringing a partner like that into a new jurisdiction, you've got to work very closely with them. We are regularly on very early morning calls with them. Yeah. And it's just around how the teams are going to work together very closely as you're mapping out things like, different date lines and time zones and all of those sort of operating details that have got to be worked through.
Excellent. That Danish model really talks about self-management and technology that was there, actually. So, he's getting the consumer to do the work sort of for them. How far are you sort of on that road of be able to make it accessible technology that the consumers can use?
Yeah, look, for me, Phil, it's just such a passion area. Prior to being with Amplar, I had the opportunity to work in the largest self-managed home care model in Australia, and I learned an enormous amount of what you think the model needs to look like in traditional home care versus when you're running virtual care management as your model. What looks different? What do you have to approach differently? The mindset is quite different. You know, when you're thinking virtual first, what you might assume in a face-to-face interaction versus what it looks like virtually. But I think, you know, that's an area that we're looking to push into quite significantly, and how we make sure that care, the quality of care is still really high. We're capturing the right evidence around how to adapt those models, and importantly, making them as accessible as possible to people.
And the technology itself, how accessible is that for those consumers to use? You talked about that orange box,
yes,
at least when they come out of into hospital or in the home. What's available on the preventative side currently? Yeah.
Look, I think with that, again, you know, you try to make it as simple as possible. So, you know, the services are available on an iPad for people. I think, again, one of the kind of myths that have been in the sector for a very long time is that, you know, our consumer cohort are not very tech savvy or engaged with it. But in fact, we find the opposite with that. And I think when you're offering a person the opportunity to spend that time in their own home with their family and loved ones, with their dog on the bed, with their meals, rather than being in a hospital, people are very quick to sort of adapt to the tools.
Yeah.
And similarly to Hans-Erik's comments, you know, when people are provided with the kit, which is tailored to their particular requirements, you remove a lot of those barriers that you might see if it was just a generic option. But we make sure that what people are provided with is very specifically tailored to their particular health challenge.
Yeah, and I would say, actually, as you might see out in our stand at the moment, we've got BestMed, what's called Home Dose now, which is a medication self-dispensing device that gives that data back, most importantly, when somebody hasn't taken their medication. So, and it's built by industrial designers in Melbourne. So actually, there's no screen on it. It's actually very easy to use, so it can go up in all of those cohorts. And there are actually a dementia patient, a consumer who's using that and has actually been able to remain at home for 6 months. So they were facing the choice of when their care worker was leaving, that they were going to have to go into residential care, but they were taught to go back to that device over a period of 3 weeks. And 6 months on, they are still actually able to stay at home, and the level of care intensity is much lower than it sort of would be actually.
And no doubt they are far, far happier.
Much sort of happier as well. And I think similarly from those, inspiration for those devices as well came from the Nordics too. So there's about 40,000 of those across the Scandinavian sort of countries. And that actually reduces as well the care intensity that you need at the peak morning medication round. So it's 22% lower hours that you need at that kind of 8, 9 o'clock session. So you can spread your resource through, and it's 9% sort of across the day actually. So more
That's
empowered,
fantastic, yes.
and actually you've got better data that we'll get through.
Yes, and the monitoring sounds like it's gives people that sense of reassurance if they haven't taken the medication.
Yeah,
so
over there.
it's brilliant.
I guess because just on the Danish model, I mean, Denmark does spend 47% of its GDP, or the government spends 47% of the GDP compared to 38% sort of in Australia. How much do you think is that creating, and it's much more probably compliant culture probably in Australia? Do you think how much of that model can we sort of bring down, and will Australians accept?
Well, we are known as the country internationally through recent history that takes up new technology faster than anybody else. We also have the situation that going forward, we're going to be paying more for our health, and we don't like paying. So combine those two facts alone, I think people are going to put 2 and 2 together. And then if we can't get access to the experts that we expect to look after us in the time frame that we like, you know, one of my favourite stories is there are so many developers putting land lease, for instance, into Hervey Bay, but you can't get a doctor in Hervey Bay. Mm-hmm. So, you know, yet another 200 homes are going in, drawing people up from New South Wales, but you can't get a doctor. So again, I think word will get out just amongst peer groups that this thing works, and I can, as Hans-Erik was saying, you know, immediately I get somebody.
Yes.
So I think the adaptation will be fast. And is that your experience?
Oh, without doubt. And, you know, in our GP business, you know, we've set the target that we're going to have 50% of those consultations delivered virtually. So the accessibility it provides for people, as well as the the efficiency of delivery of those models just means that one GP can actually support a far wider number of clients in that space.
And I think you said in your presentation, 700,000 virtual connections?
2.3 million.
Sorry,
virtual interactions.
2.3 million. Yes. It was a big number.
Yes, it is a large number.
Over 12 months, you've had 2.3 million virtual interactions. So what would be an interaction?
Look, across the continuum. So, we're talking about prevention being delivered digitally. We're talking about nursing, support being delivered via video, allied health as well, particularly around mental health. We have a virtual psychology clinic right the way up into our GPs. So we have a really strong commitment around the virtualisation of the service delivery because, as everybody's talked about, there just aren't enough of our clinicians to continue to deliver that one-on-one, face-to-face service delivery. The virtualisation of those models will absolutely increase the capacity. And so, from a consumer perspective, they have benefit. The clinicians themselves are working at a higher scope of practice, and from a funding perspective, it's more cost effective. So it's a model that we're very committed to continuing to grow.
I notice that we've only got about 3 minutes left of this session. I can't believe it's gone so fast. We should perhaps ask the audience, does anybody have any questions that you'd like for Phil or Bev? Stunned?
Consumptive fatigue.
Whilst we're waiting, see, there's one final question. I had one. You talked about people operating at the top of their licence. Have you seen that benefit in terms of retention of sort of staff? And what sort of programs did you sort of put in place to sort of skill them up for this? Yeah.
Look, again, it's about how you reduce the administration workload on whichever roles you're working with, the nurses, GPs, etc. So that's where we're implementing capabilities like auto-transcribe. So when the consult is done, that is recorded. There's not somebody sort of painstakingly sort of typing away at their notes. The consultation is auto-transcribed. That's translated into the referral letters, and then that's able to be sent off while you're still in the consult. So it's using technology at various stages in the process to take out more of that administrative work, which means that the clinician has more of their time is spent on the higher scope of practice activities.
Excellent. And I would say I think also virtual does help to lift that productivity. So one of the things we saw in COVID, we're employing emergency specialists and everyone thought they won't have enough hours because they'll be in hospital all the time. Actually, what you found is they made time because actually when you account manage physicians really well and you look after them, they find the hours for it. And so even when Omicron hit and we went up sort of fourfold in calls, actually the physicians leaned in actually, and that capacity expands actually. And that's one of the things we don't always think about, particularly that chart that was up this morning shows that we've got a long way to go in terms of productivity, in terms of the workforce.
Absolutely. And we get much more positive feedback about people feeling that their time is spent on the right things. So that's across the continuum of capability, which is great. Excellent.
Is there any one final question out there before we go after that? Yes, if we can get a microphone. It's just coming for you now. Somebody's running. Oh. There we go.
Thank you. Just curious to understand if you've got any feedback from your aged clientele that might be utilising your service and how they find the technology, because we often hear that that's a bit of a barrier for them to participate and participate well.
Look, on the whole, I think that there is positive feedback in terms of the flexibility and accessibility that it gives people. There's no doubt for the builder generation, as Cam Ansell was calling it, those people may require some assistance from family members in terms of, sort of logging them in. But what we try to do with the iPads is to make that interface as simple as possible. And after a couple of times through it, we find that people can pick it up pretty intuitively. So it's something that we sort of are very conscious about what the user experience is and making sure that we do keep it nice and simple.